Hi, everyone. Welcome back. Today, we're joined again by Dr. Stenehjem to give our weekly COVID-19 update on the state of Utah. Dr. Stenehjem, thank you so much for joining us. We really appreciate it.
Thanks, Amanda.
As always, I want to start with case trends and what's been going on since the last time we spoke. In total, for the state of Utah, we have had 143,639 cases. Yesterday's case counts was 3,919, with a 7-day rolling average of 23.2% positive rate and 2,738 cases. Our death count is up to 687, and yesterday's death count was 9 people. Our hospitalizations throughout the entire pandemic has been 6,487, and yesterday's hospitalization status was 468. Our ICUs, as reported across the state, were at an 83% occupancy rate. Let's break that down a little bit. How are we doing? What have we seen since last week? Obviously, there's been a large jump, and what does that mean? What are these from?
Yeah, first of all, we got a little visitor. There's Pooch. He's joining us for today's Facebook Live. That's
I like it.
Yeah, he probably is not gonna have any questions for us. Yeah, yesterday was a really bad day. Amanda, we had almost 4,000 cases announced yesterday. That's almost 1,000 more than our highest previous. If you look at the curve, we're in this kind of logarithmic kind of increase in cases. It was really, disheartening for a lot of us that are in this work in terms of the case counts yesterday. We're seeing cases everywhere. Essentially all of our counties are hotspots at this point. We all have high case transmission, all Wasatch Front essentially, and down in Southwest. We're seeing a large proportion of cases in that 15 to 24-year-old age group. That's where I won't say majority, but that's where a big section of cases are coming from. We hypothesize that what we're seeing right now, this huge increase in cases, is coming from Halloween. And we saw across the state a number of Halloween parties and people not following public health guidance. And we're thinking that that's what this is from. And we know that from previous kind of experiences that once you have cases in the 15 to 24-year-old age group, they go home, and that's where you get this kind of amplifier effect where then they transmit to their family, their parents or grandparents and community members. And so that's one of the major routes of transmission. When we look to the hospitals, keep in mind that the cases identified yesterday, those will end up in the hospitals in 7 to 10 days. They're not in the hospital right now. And so our current hospitalization numbers really reflect 7 to 10 days ago. And when you look at the curve, whether it be our Intermountain internal data or whether it's the state data, our hospitalization numbers keep going up daily. And so they're going to continue to go up regardless of what we do right now, because hospitalizations is one of these delayed metrics that we're really, it's dependent on the data from 7 to 10 days ago. From a hospital standpoint, we're getting to a really critical place. We've been saying this over and over again. Now it's coming to reality that the care that we're providing our patients right now in our hospitals today is not the same care as it was 4 weeks ago. The care is different. It is palpably different. It is not the care we want to give to our patients. It's the care we have to give to our patients. Examples of that is that there are non-ICU trained nurses taking care of ICU patients. Another example is that patients that need the ICU are now in an ICU, which is a floor, a general medical floor. At Intermountain Medical Center, we have turned one of our cardiology general medical floors into an ICU. That's not typical care that we would like to provide. We've opened up ICUs at LDS Hospital, at IMC, at St. George. We're converting other medical surgical beds that aren't typically med-surg beds into beds to care for COVID patients and non-COVID patients. We've had to activate teams of advanced practice providers, NPs and PAs, that are supervised now by a hospitalist-based physician to care for these patients. And we're having to activate these teams as we go, as more and more patients come in. So, we've said it before, right now, it's not necessarily the beds. Like, we can find places in the hospital to put patients. Like, we have large hospitals, we can find the beds. It's the caregivers. Our caregivers are getting sick as well. And so that's becoming a challenge. They aren't getting sick from the care of patients in the hospital, but they're getting sick from the community. And so it's a pretty scary time right now to be in the hospital.
I have a quick clarification question, just so people understand. What makes a ICU bed an ICU bed compared to like a med surg bed?
Great. Yeah, really good question. So an ICU bed is typically in a location that has really intensive monitoring. And so it's essentially a room dedicated to critical care needs. And so it has the ability to have a ventilator, have the advanced monitoring, have the advanced cardiac monitoring, have all those things right at your fingertips that you need in case that patient were to continue to deteriorate. And so it really brings all of those things that you need to care for a severely ill, complex patient, whether it be on a ventilator or they need dialysis. Any of those things can be done right there in the room, as opposed to a medical surgical bed, which is not nearly as monitored and doesn't have those abilities to have a ventilator and some of these other advanced therapies that patients need. So it's a very specialized room to care for really, really sick patients.
I think that's helpful to understand when we look at capacity and kind of what that means. If you've never been into an ICU unit, you might not know that. I want to talk about the future. So the governor enacted this 2-week pause that started about 4 days ago, and we have Thanksgiving coming up. First question for you. With the pause that started 4 days ago, when can we actually expect something to change if people are following all those guidelines?
Yeah, so, we had this discussion internally amongst our, ID and epidemiology experts in terms of when would we first get a glimpse of possible changing this curve. And we thought probably 10 days in is really when we'd probably see this. And so, we're 4 days in at this point. We're not seeing the impact of these interventions. I also want to highlight the interventions are a great start for the governor to come out and make these, public health mandates. But it still is dependent on community engagement to change. And so, we were at a 90% mask mandate across the state based on our transmission index. The governor's asking no social contact outside of your home for 2 weeks. Well, that's all talking about engagement. Nobody's enforcing that. The extracurricular activities is great in terms of stopping some of this after school transmission. But there's still plenty of private businesses that are holding cheerleading practices and karate practices and all these other things. And so it really, these are good public health mandates. The question of, is it going to be enough, has been raised over and over again. And I worry that, it's based on community engagement. And is the community willing to do this for a 2-week pause so we can drive our cases down before the holidays? I'm not sure if it's enough.
Speaking of the holidays, like you said, you aren't sure if this is enough. So what are your suggestions for Thanksgiving? It's in about a week and a half. It's coming up quickly. What should people be realistically doing for the holidays?
This is such a delicate balance between, the mental health of our community and transmission of the virus. And, before we get into that, I do want to, just give a shout out to all of those people in Utah that are doing the right things. And I don't want us to take away like nobody's doing anything. There are huge portions of the population that are following public health guidance and are staying home and wearing a mask. And, from one caregiver to them, thank you. Thank you for doing that. And please continue to do it. I know this is hard. I think they haven't been recognized enough because we focus on this small portion of the population that doesn't. So I just wanted to take a second and say, thank you to all those that are helping us in healthcare. Without you, we would have been overrun weeks ago. So thank you. In terms of Thanksgiving, it's that push and pull, right, between mental health and spending time with your friends and family versus transmission of the virus. Given where we are right now with such high transmission levels, we know that if you are bringing people into your home and are not wearing masks and not, abiding by any social distancing, we will have increased transmission, just period. And so if you want to be as safe as possible, limit your Thanksgiving to just your members of your family that live in your home. That would be the safest approach. And that's the approach that, my family is doing, and we've had to make some hard decisions about that. But it really is going to be a risk. And if you have vulnerable people in your family, people that are older, they've got chronic medical conditions, and you are bringing people into your home and sharing that time with them, that is a really, really high risk of transmission of the virus and a potential poor outcome for that individual that is older or has chronic medical conditions. So, the recommendation is really limit your gatherings to those that are in your home.
It'll be interesting to see what happens. And like you said, it's really up to the community to make those choices on what they decide to do. So yeah, those are hard choices regardless. And someone made a comment about mental health could be a lot worse if someone ends up getting sick, which is very true. You wouldn't want to be the reason that someone gets sick and then potentially ends up in the hospital. So things to think about for the next week. I want to move on really quickly and talk about the increased testing that's happening specifically with university students here in Utah. I was having a conversation with someone about this and they asked me, well, aren't case counts just going to continue to go up if we start testing more people, particularly those university students? And what kind of happens with that when the testing does go up?
Yeah, so this is what makes comparison of case counts across states difficult, because your case count is very dependent on your testing strategies. And also not only your case counts, but your test positivity rate is also very dependent on your testing strategies. So if you're not testing enough, you may have low cases, but your percent positive of your cases is going to be really high because you're only testing people that are very likely to have the disease. In areas that have lots of testing, you may have high case counts, but you also may be detecting asymptomatic individuals. But what you'll see is because of that high amount of cases, your test positivity percent will be low. Okay, so when we think about increasing testing here in the state of Utah, which has already had pretty good access to tests, we had 13,000 tests done the other day. If we're now bringing in a lot more tests to test a population that's typically asymptomatic, but generally have lower rates of infection, what you'll see happen is, your case counts may go up, and you'll have to really watch the demographic trends in this because they're going to be targeting that 15 to 35 year age group. Your total people tested positive will go up, but we'll see a decrease in your test positivity rate. And so you're absolutely right. More testing is going to result into more tests done and more positives found, but it should also decrease your test positivity rate. And so it'll just have to be something we monitor closely as we go through and be able to understand why we're seeing those changes. The important part is in that age group is identifying people that are asymptomatically infected and taking them out of the pool. And by that, we mean having them isolate. And so then they aren't continuing to transmit the infection to their peers, to their friends, to their family. And so it's not just testing, but it's testing in conjunction with self-isolation when you have a positive test.
And there's a lot of tests, different types of tests that are being done. I know the University of Utah is using the rapid antigen test. what's the accuracy level of that specific test compared to, say, the PCR test that we run?
So this first generation of antigen tests is not nearly as good as the PCR-based tests that we do in, across Intermountain or the University of Utah. The benefit of the antigen test is they're fast and they're very easy to perform, and you can have a result in 15 to 20 minutes. When we look at, symptomatic patients that are coming into our facilities, we do a rapid antigen test just so we can get a quick result. And in those people where we think they have disease, a positive test is really useful. But if they come in and we think they have disease and their test is negative, we will reflex that to a PCR test. And so we see, in initial people testing negative, we see a significant proportion having a positive test by PCR. So when we think about the sensitivity of the test, meaning of the people that have the disease, how many test positive with an antigen test, it's only about 70%. But that's in people with symptomatic disease. In people that are asymptomatic, the test is actually pretty good because you already are a kind of a low suspicion that they are infected, and a negative test lowers that even further. Okay, so it's a really challenging way to think about these testing. But in people that are low suspicion of disease, an antigen test negative helps you, but you sometimes will have false positive tests as well. So it's really tricky in these kind of first generation antigen tests and how to use them. But they are good in screening populations that are at low risk of active infection. And so that's why they're going to be used in the university setting.
Do you know by chance too, when the case counts reporting starts happening with these university testing, if there's going to be a separation for how the state records them? I know that Dr. Dunn yesterday mentioned the 1,100 football players that were tested and the percentage there. Do you know if they're planning on talking about the difference between the university testing and the community testing?
That's a great question. I don't know the answer to that. I would suspect that they would, potentially be able to report that on their Utah Department of Health website. On the website currently, it breaks down the number of tests that are PCR tests versus antigen tests in their daily reporting. I'm not certain if they're going to pull that out. It'd be really interesting. I hope they do, because that is really testing of an asymptomatic population. So it would be very interesting to pull that out, but I'm not certain if they will or not.
We'll follow up on that one with them. Another question for you. How can someone stay safe if they're living with someone who is a medical worker who currently deals with COVID-19 positive patients?
Yeah, I mean, I think what we're seeing across our facilities is that medical workers that use the appropriate personal protective equipment, or PPE, that they're safe. And so, we aren't seeing lots of cases in our healthcare professionals that are caring for COVID patients due to transmission in the hospital. We know that in that safe, protected environment, if we're taking all those precautions, using PAPRs and washing our hands and gowns and all that, our caregivers are staying safe. It's in the community that when they leave the hospital and then are exposed to friends and acquaintances outside of the hospital without that protection equipment, that's where we're seeing transmission. And so I can say what we do, when I'm in the hospital seeing COVID patients and non-COVID patients alike, I come home, I change my clothes, I take a shower, and then I engage with my family like I normally would. And so unless there is a significant exposure where you were unprotected, caregivers remain relatively well protected while they're caring for patients, and they just take some precautions with their family as they're coming home. But as for kind of, are they particularly high risk? As long as they're using the PPE that have been set forth for them, and then we have access to PPE, they're a protected population, and their risk is probably higher in the community if they're engaging with people that aren't wearing masks.
Hopefully that helps and ease up someone's concerns with that. And yes, you are someone who deals with COVID patients, so you're a great example of what you do. I don't know if you'll be able to answer this, but someone asked, what is the effect on a young baby, say 3 months old, that potentially gets COVID-19? Do we know anything about how babies who are contracting the virus, what what their symptoms are like and how they're kind of dealing with
Yeah.
it?
Yeah, it's a good question, and one that's been posed to our pediatric infectious disease colleagues as well. I mean, nationally, they say babies less than 3 months are at higher risk of severe illness, although those numbers have been really pretty small. We don't have, hordes of really young infants at Primary Children's Hospital right now. Certainly they can get sick and they're at higher risk just because of their age and their fragility. And so, yes, they're at higher risk, but we're not seeing the overwhelming numbers that we would expect if they were at particularly high risk for a negative outcome for this. I mean, babies continue to be born in Utah, right? And so we're not seeing huge numbers of infants in our hospitals up at Primary Children's at this point. So that's quite reassuring.
I know some people personally who, if someone comes over to see their baby, they will wear a mask just to be sure, make sure their hands are sanitized, clean, and everything like that, just to double check everything and make sure that the baby is safe. So that's one way you could potentially keep the baby safer too.
Yeah, and I mean, as a father of now an 8-month-old that was born in March, at the middle of this pandemic, it's crazy how few people have met our son. We have good friends in Salt Lake that have not met him yet. And that's just because we're being very cautious in terms of how we engage with our social networks here. And in the way we see it is, Ernie, our son, he doesn't care. He's not going to know the difference. But we're keeping him relatively sheltered along with our daughter. But that's just out of an abundance of caution.
He's going to have a lot to talk about when he's older.
He will.
Pandemic baby dealing with a dad who did a lot for this. So that'll be interesting when he grows up. But I want to talk really quickly about delaying care. There's been this assumption that as our hospitals get more full, that it's harder for someone to get care if they get into a car accident or something happens, or even just if they have a heart attack, they're delaying care. Why is it so important for someone to get the medical attention that they need? And then what could happen if they cannot get the medical attention they need?
Right. I mean, we've seen this time and time again over the past few months at Intermountain Medical Center. Just some cases from my work in infectious disease. I've seen a bunch of patients coming in with severely infected wounds on their lower extremities that are a complication from diabetes that they just let go because they just didn't want to seek care because they thought it was unsafe. And what happens then is that they're coming in at a later stage of their illness, of their infection, and we can't treat them as well. And so we've had a number of cases where, people come in with severe wounds on their lower extremities that they just waited too long, and that has led to amputations. Whereas if they came in earlier, we would have been able to treat that effectively with antibiotics and some minor surgery. We've seen the same thing nationally and also here, in people delaying care for chest pain, and the fact that they're coming in now with the severe complications of an untreated heart attack. Same thing in stroke patients. We saw a decline in the number of strokes that people have been cared for and having later manifestations of strokes because they didn't seek care initially. This is, a byproduct of the COVID-19 pandemic. It's this not seeking care because of concern about safety issues. And so we really continue to make sure that the public knows that if you have symptoms of a medical condition that warrants attention, you need to get in and be seen. And right now you can do that. But the challenge that we are, fastly approaching is that those beds that we need to care for those non-COVID patients may be very, very limited as we move forward in this pandemic. And so if you are in a car accident, or you do have a stroke, or you do have a heart attack, it's going to be harder and harder for us to find not only a bed for you to go into, but a caregiver to manage you. And so, trying to understand, well, what is the big deal about filling our hospitals with COVID patients? Well, the big deal is that, one, they don't get the care that they need, but two is that the care that you need for non-COVID related issues may not be there when you need it most. And that's really just the sad fact of what it looks like. And that's what's happened in New York City back in the spring. It happened in Arizona. It's happened in Italy. It's happened all places across Europe. And unfortunately, we're on the path for that to happen in Utah.
I think that's why this 2-week pause is so important as well. It kind of hopefully will help the hospital system catch back up to keeping the census a little bit lower, getting people to be able to get the care that they need.
That's the whole point of this. What we hope is an effective 2-week pause is that what'll happen is if we can drive down that transmission rate, it's not going to go to zero. We know that. But if we can drive that down and get some breathing room in the hospitals where we can manage these high volumes of COVID-19 patients and all the other patients, we know we're going to be busy. We know we're going to be activating teams. But if we can maintain the care that we want to provide to both COVID and non-COVID patients alike, that's a win for us. And we need to be able to then maintain that transmission rate as we go forward until we get, out of the winter, get an effective vaccine, et cetera.
I want to address a quick rumor that someone posed a question to us. They said that markers used to test for COVID-19 are also being used to test for the flu. Could our numbers potentially be going up because everyone is getting the flu shot and it's creating a false positive for COVID-19?
Yeah, no, absolutely no truth to that. So the way we test for influenza, there's 2 tests for it. There's the PCR-based test. That's the same type of test we have for SARS-CoV-2, but it looks for the genetic sequence specific to influenza A or B, which is very different than the spike protein or the genetic material that we identify in SARS-CoV-2. So the flu PCR test and SARS-CoV-2 tests are completely different. If they weren't different, that would have been a great way for us to detect SARS-CoV-2 back in the spring. We wouldn't have had to redevelop new tests. So the testing for flu and SARS-CoV-2 are completely different targets. If you talk about the PCR test or the antigen test, there's no overlap between those. We've been testing a lot for influenza recently because we're just starting to get into the influenza season. We see high numbers of SARS-CoV-2, but we see essentially 0 cases of influenza. So there is no overlap between the testing. Maybe what the listener is referring to is monitoring of something called influenza-like illness. So influenza-like illness is fever and a respiratory symptom. That's a syndromic definition that the CDC and public health partners use to assess when we're seeing influenza in the community that doesn't require a test. And that's going to be, modified to have an influenza-like illness and coronavirus-like illness, but there's going to be overlap in those, but that's not a test-based strategy that we're reporting anywhere. So the actual testing of influenza, whether it be PCR or antigen, totally different than SARS-CoV-2.
And I know this person mentioned everyone getting the flu shot. I think last year in Utah, only like 40% of the population actually got the flu shot. So it's an interesting statistic. I'm not sure what the state's at currently for that, but it will help the hospital system to not be overrun by flu patients and flu hospitalizations. So if you haven't gotten your flu shot, you should still get it.
Yeah, absolutely. And after a flu shot, we don't test people with antibodies for influenza. Like that's not something we do. And the influenza, the flu shot is not a live virus. So we can't look for PCR for the actual virus. So, after a flu vaccine, there's no test that we do to determine whether they've had it or not. We don't test for antibodies or anything of that nature. So I'm uncertain what that listener is looking to, but absolutely get your flu shot if you haven't done it yet.
Last question for you. I want to talk about the vaccine. On Monday, Pfizer came out with a report that their vaccine had a 90% efficiency rate for the vaccine that they're currently running. What are your thoughts on this? What does that mean? I know they're only one of many. And when can we potentially see like the general public, me, for instance, who's not a frontline healthcare worker, I'm not in a high risk category. When could I actually expect to be able to be given the vaccine?
Right. What amazing news that was released on Monday by Pfizer. We could not have asked for a better first look at the data. Like, absolutely not. Nobody expected this to have a 90% efficacy rate. So let's just talk about that 90% efficacy rates for a second. So how do they look at that? So they have something called the Data Safety Monitoring Board. This is an independent group of scientists. By independent, I mean they have no relation to Pfizer at all. This is a voluntary group that they put together. And they get looks at the data at intervals to ensure that the study doesn't need to be stopped due to safety reasons or futility for that matter. And so they have planned looks at the data to make sure that it should keep going from a safety standpoint and that it's not futile, meaning that it's not showing any signal at all. So in these coronavirus studies, they plan these kind of looks at the data at time points that are reflective of their endpoint. And so for Pfizer, for example, they said, we're going to wait until 90, well, the original plan was 60, but it ended up being 94. 94 people have gotten symptomatic COVID-19. Okay. And so they waited, they had 94 people. They said, okay, let's take a look at the data. They sent it to the Data Safety Monitoring Board. And then what they do is they say, okay, let's look at those 94 people that got the infection, and then let's unblind them, meaning let's see how many of those 94 people got the vaccine and how many got placebo. And that's where you determine the efficacy. And so over 90% of those people that got COVID-19 actually had gotten the placebo, meaning that there's very few people in that group that got the infection had received the active vaccine. And so this is a really good sign that the vaccine is effective in a short term. In the Pfizer study, they're just looking at symptomatic COVID-19, meaning did you have at least one symptom of COVID-19? It says nothing about hospitalization. Okay, so we don't know if the vaccine is going to reduce hospitalization. We don't know if it's going to reduce death. All we know is that in this first look, that it was 90% efficacious in reducing symptomatic COVID-19, which is awesome. I mean, that's just exactly what we wanted to see, but we're certainly going to learn more. They still have to get over 150 of these primary endpoints to be able to apply for a FDA emergency use authorization. But given what's happening in the US in terms of this surge in cases, they're going to get that very, very shortly, I would imagine in the next coming weeks. And then that would be then an application to the FDA for emergency use authorization. So if everything continues as it is currently going, that the vaccine continues to show really effective results, we suspect that they could potentially file for an FDA emergency use authorization by the end of this month, with potentially, vaccine being shipped in early December. And like you said, the first target audience will be frontline healthcare workers and emergency response workers. And then the next phase is going to be those people at highest risk for severe outcomes for COVID-19. And so general public distribution of the vaccine, I think most people are kind of talking spring to May, June of next year. But, our primary focus is to protect our caregivers. So we are there to care for people, and then try to reduce the number of people that are going to have severe illness from COVID-19, meaning the older population, those that have comorbid illnesses, to prevent deaths. And so then we'll be rolling out to the general public. A lot of this is going to be based on state guidance, and not necessarily independent practitioner guidance.
You mentioned protecting healthcare workers first. Someone just made a comment about how in New York during their surge, they opened up a field hospital that was staffed by medical military personnel. Part of Utah's problem right now is that we don't have enough staff. I know Intermountain's perspective, we're hiring more people. We are bringing in traveling nurses. We have people from New York that are here. Is there a group of people that is, quote, qualified enough to start helping us, or when do we reach that critical point where we bring in the medical military group or do something further?
I mean, so one of the challenges we have is that it's not just Utah that is having a huge spike in cases and challenged by the healthcare resources that they have. I mean, North Dakota, South Dakota, Iowa, Minnesota, Wisconsin, Michigan, Illinois, all are in this same situation. Okay, so it's not, like back in March, it was New York City and surrounding communities and boroughs, a little bit up in Washington, so we were able to focus our efforts on those areas. Now it's essentially all of the Midwest. And so that's just a much larger area for people to go and help. And so you're right, we are bringing in traveling nurses. We've brought in about 30 caregivers from New York City that are kind of repaying the favor that we provided to them. But a lot of it's going to be going within our Intermountain healthcare communities to say, okay, who can help us with this? So a great example is, all those anesthesiologists who are monitoring operating rooms. Those people are very well qualified to run ventilators and to work in the intensive care unit. And so we'll be calling upon them to help in the ICU, which would then be kind of supervised by an intensive care unit physician. Urgent care docs and primary care docs who may not have worked in a hospital for quite some time, but they certainly have the knowledge and the ability to be, trained up and manage patients like this, will be pulled in to help out in the hospital. We just can't count on, kind of military hospital staff to come in and help us with this. If we have to spin up a field hospital that the state has made plans for, I think that's where, that staffing is going to come into play.
You brought up a great point about that it's not just Utah. I think yesterday the report said we were number 15 in the US. Don't quote me on that, I could be wrong. But in terms of case counts and positive rates, so there's 15 other states potentially that are having this exact same issue worse than us. Yeah. So yes, we'd love to have these people come in and help us, but like you said, it's not just us. So it'll be interesting to see what happens. Hopefully these traveling nurses give our caregivers the opportunity to breathe a little bit and to take some very well-deserved time off to kind of recharge. So Eddie, is there anything else that you'd like to mention to us today about what's been going on? Any other updates the community should be aware of?
Yeah, I mean, I just think we're at a really critical point here, and would just, ask everybody to be part of the solution. And so that means no social gatherings. That means not going out, not being involved in congregate settings. This is a huge sacrifice we're asking everybody to do for the sake of our community. And we're not done with this. And unfortunately, we're kind of entering the hardest part. The fact that we're tired of this. It's now winter. We're not outside. We're not having, outdoor barbecues and drinks. We're indoors. But just, don't lose faith in this and the fact that we will get through this. And we just hope that we can protect our vulnerable populations as we go through this, but we'll get through it. Vaccines are coming. They're not going to help us right now, unfortunately. They're going to help us in a couple months. Therapeutics are coming, but they're not going to be here ready for us today, tomorrow, or next week, but they're coming. Advanced testing is coming. That's going to help us. That's going to help us reduce our caseloads, but that's not going to be set up for another, couple months. And so the next 2 months are so critical for all of us to, forget our differences and just say, let's do this. Let's continue to sacrifice. And this is just a crappy time to do that. I mean, it's Thanksgiving, it's Christmas. This is the time we look forward to. And so this just sucks. But I would just say, just think about all those makeup parties, think about all those makeup family gatherings that we can have in March and April when we're on the other side of this. And let's focus on that and just forget about all the noise of this and just say, let's do it. We're going to hunker down and we're going to not do these activities, and we're going to do the best we can. And we're going to try to stay as mentally healthy as possible, which is really hard, but we're just going to do the best we can. And we don't have any other option. That is our only option for us right now. The other option to not do that means that lots of people are going to die. And we're really going to kind of injure our healthcare setting, and it's going to be even worse than if we don't. So I think, that's where we're at, Amanda.
Dr. Stenehjem, thank you so much. We really appreciate you taking the time to talk with us. And a couple of resources for people really quickly. We are looking for frontline caregivers to join our team. You can go to intermountain.jobs/openings and look for clinical caregiver work options available throughout the state of Utah. We also still have our arrival window system in place for testing. You can go to intermountain.com/COVID testing to find out if you qualify for a test and set up an appointment arrival time to get tested. We also have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Thanks, everyone, and we'll talk to you next time.